multimodal imaging in this day and age. Right? And the reason for that is because one modality alone is not enough. So can you spot the rhino among the zebra? And it's so dangerous, right? I mean, now with litigation and other implications, right? So we really want to use whatever is available to us. And yet, as Wei Kiong said, I like his term, is not a buffet syndrome. So we have to be specific. What are you looking for, and what is the best way to get at the diagnosis? I found that the Zeiss forum system has really helped in that respect. It doesn't tell you what the diagnosis is, but what it does is to bring all your imaging modalities all on one page. Right? So it's a dedicated ophthalmic picture archiving and communication system. We have been waiting for something like this for a long time. Individual vendors have been trying to come up with a suitable system with thumbnails and so on. But I think that this is the first most practical application of this. It is very relevant for us in glaucoma and retina and in cataract. Of course, the limitation is that it works only on Zeiss machines. You can pull in using the other images, but they appear as thumbnails, right? And they are sort of PDF type of images. So you can't analyze if you have pulled in an image using a non-Zeiss equipment. Actually, if you look at it from another point of view, maybe from a marketing point of view, this is a really good reason why you would want to use a Zeiss machine, right? Because you would then be able to integrate all these really all under one roof. I mean, typically, we started with visual fields. It's undoubtedly going to be Zeiss, Humphrey's visual field, and now with the OCT, with the Cirrus, you're able to then integrate structure as well as functional change. How it works is really very simple. You start off when the patient checks in, and what I like is it automatically populates as the patient moves along the patient journey in the clinic. So as he comes round from vision, we don't need to repeat data. He goes in, dilation, gets the scans done or visual fields done. So at each point, there is no risk of transcription error. The work list is scheduled. I can see immediately on my screen as the patient goes through the clinic what stations he or she has already completed. And after the examination, I can then review even before the patient steps into my room. Of course, with surgery, that's really for cataract. I think another advantage is off-site. I think this morning you heard from Smita the advantages of having the forum open images across your locations. Right? So many of us practice in different places. We don't need to repeat those tests in those individual locations. Well, I think most of you are still familiar with this. Our windows are sort of overcrowded. I had to open a Heidelberg and I had to open a Topcon and so on, right? And it was really inefficient and really annoying. The Zeiss forum allows us to see everything on one page in a chronological order. Every single image obtained for the patient, whether using a Zeiss or non-Zeiss instrument, it really doesn't matter. For example, some of these images were taken on non-Zeiss machines. If you open those images, you will be able to view them on the forum, but you can't analyze them. Okay? And the Retina Workplace is really targeted at monitoring changes, particularly on the OCT, and now also on the OCT angio. And how I've used it is really not just for diagnosis, but more importantly, to be able to track changes to their macular change with treatment. Many of us are, in the era of anti-VEGF treatment. And actually, without imaging, anti-VEGF treatment, I think, would not have taken off in such a meaningful way. So the bedrock of any retina workplace or any similar software is registration. If you cannot compare apples with apples, then whatever conclusions you come to will be, in fact, inaccurate and even misleading. So multimodality image registrations is really a very powerful feature of the Retina Workplace. Here you have the ability to have 3 visits, usually a first, prior, and today's visit, or you could change whichever visit you prefer. You could set one as a baseline with subsequent comparisons. Right? This is a patient with cystoid macular edema, subsequently followed up prior visit, and then the current visit where the macula is almost dry. All on one screen. Another nice feature is the events. So you can see at the bottom the ability to chart both a foveal thickness, which is of course visually significant, and another parameter, for example, average macular thickness or even volume. Right? So you are able to then, in a graphical way, look at changes. And as Harvey mentioned earlier, now our patients are so well trained, they at one glance will be able to tell you whether they are likely to need an injection or not. Right? And you can then chart at each of these events a particular treatment. So you could, for example, put in the times at which maybe Eylea was given or Vabysmo was given, and then calculate the duration between these treatments. One of the feedback we've given Zeiss is we should also have it in weeks. After all, most of our treatments are targeted at how many week intervals once you've gone beyond the loading phase. Here, currently the software only calculates the number of days between intervening treatments. So there are many applications. I think if you have the forum, I would highly urge you to get a Retina Workplace if you see and manage retinal patients to detect, compare pathological changes, and it's powerful because of registration, to visualize at one glance treatment efficacy with the history of the patient's treatments. I think in the future it will be integrated with our EMRs. So I know that Zeiss is working on this whole sort of ecosystem where the EMR events are reflected in the investigations and vice versa. You heard earlier about the advanced RPE analysis. This is going to become more and more relevant, not just for geographic atrophy, but also pre-geographic atrophy. I think if we want to effectively prevent blindness, we want to be able to pick up patients who are at highest risk of losing vision and progression even before they occur. And we know that in the past, it is a sub-RPE change and RPE change which has been very difficult to measure. And so here we have the opportunity with advanced RPE analysis to accurately map this out in a quantitative as well as qualitative way. And this is an example where the drusen have become more and more confluent between visits, and we know therefore that the risk of both neovascular as well as geographic atrophy has increased. The on-fast analysis is also very useful. I use that quite a lot, mainly for the sub-RPE space. But for the VR surgeons, they would of course use that for the vitreoretinal interface. This is a case example of mine, the macular edema secondary to central retinal vein occlusion. You can see the events charted below at the baseline, and then after treatment, the macula is now dry with a recurrence later on. And you can see that very quickly you can make a treatment decision. There will be many cases in AMD, for example, where you have to choose a treatment regimen, whether you do it as needed, PRN, or on a treat and extend basis. And you will see that when you input these treatment points in that graph, you will immediately be able to appreciate what treatment regimen the patient has been on. With myopia, we've heard problems in glaucoma detection and diagnosis, but also actually in maculopathy. It's not easy to detect choroidal neovascularization, especially when they first appear. Patients may be symptomatic, but because they often don't present as hemorrhages until later on, or you don't see fluid like in typical AMD, we are really looking for fuzzy borders. And this is where the forum and the Retina Workplace gives us very, very good inter-visit comparisons with accurate registrations. This is a patient who started off in the left, recurrence, treated, recurrence in about a year later, and after that, a good response to treatment. And these patients are very, very sensitive to anti-VEGF therapy if you catch them on time. I think the next phase is really to use OCT angiography. Retina Workplace already allows us to have serial comparisons of the OCT angio. You saw earlier some examples of how it can be used. I think we are still learning how to apply this in our daily practice. But certainly it is a very powerful tool when it's used in concert with the OCT-B scans. Sometimes when you're not sure if the OCT is showing a neovascularization, that the OCT flow signal really confirms it quite readily. So in other words, the Retina Workplace incorporated into Forum allows assessment of macular disease in literally seconds because it displays, it detects, and diagnoses. And what it leads to is really accuracy, precision, and efficiency. We talked a lot this morning about digitalization, and this is one great example of how this process can better manage our patients, leading to better outcomes. I'd like to now show just one case with the forum as well as the Retina Workplace, and I can then also demonstrate how I can use the various functions of the workplace. This is a patient who obviously has had a long follow-up. Patient presented initially in 2023 with decreased vision in the right eye, with subretinal fluid. It's a type 1 occult type of choroidal neovascularization. So I've set on that as a baseline in the first frame. That's the reference from which all other subsequent examinations will be compared against. All right? So you'll see that the last two, the middle and the rightmost panels, refer to the current visit as well as the penultimate visit, the prior visit. You can always modify it. For example, if I want a particular event I want to show, I will drag that event into whichever window that I want. Why is this important? Because we are then able to pull up this image as rasters. I mentioned earlier in the morning that looking at a macular OCT is good from a broad perspective, maybe from a quantitative perspective, but very often we want to look at individual raster scans for detail. And this allows us to very, very quickly pull up that particular visit and look at the detailed images at will. Right? And so this is a patient who has responded to Eylea treatment. Now the macula is dry. What I've tried to do here is to chart all the visits in which the patient was treated. This is incomplete, of course. But you can see then the intervals I've indicated here, 97 days between each of these treatments. Right? So every time the vision got worse, and with the macular fluid returning, the patient got PRN treatment at this case. But later on, you can find that the patient actually became more and more a frequent flyer. As fluid becomes recurrent more quickly, the patient now has to go towards a treat and extend protocol. Let me pull up just very quickly the whole series of all the images that have ever been done. It refers here to mostly the OCTs as well as color fundus photographs. So all in one page, it has allowed me to bring all these images in one page without having to open multiple windows. And even if I wanted to look at a non-Zeiss machine image, I can do so and manipulate it as I like. Right? So this is just a practical demonstration of how I use the Retina Workplace. It has been really indispensable in accurately determining both diagnosis as well as monitoring of response to treatment. Okay, thank you very much. I'd like to now invite Harvey to present some of his cases, and maybe we'll have a conversation around some of them.
So this part of the session will more be like a show and tell. Let me see if we can show this. Yeah, this thing seems to be like a moving target. Okay. Thank you. Okay, so just imagine the patient's in front of you, and you find out their preferences, and then you use the Retina Workplace to address their concerns and come up with a treatment plan. So this is a 69-year-old female with retinal vein occlusion. You can clearly see here there's a lot of edema on one side of the retina. And of course, nobody really likes to get a shot in their eye, but we tell these patients, if you don't get this shot, they will wind up with irreparable visual loss over time. So the patient now agrees to get some shots. And as you can see down here on the graphical display, the green line shows the average cube thickness, and the yellow line shows the average central retinal thickness. Each dot is actually a visit where we performed an OCT, and that syringe-like symbol on top is an indication that we gave some treatment. And in our practice, we generally color code it. There's a standardized color code as to what medicine corresponds to what color. So here you can see here in the first a dot, there's edema. This is the left-handmost screen with the heat map showing a lot of edema. And we convince the patients to get an injection. We get an injection and they come back sometime later. And you can see that the yellow line has gone down, indicating that there is a good response to the treatment. And there's still some edema, so we have a second shot given, and then a third shot is pending because the patient's vision starts to deteriorate. So at this point, the patient says, I don't really like to get my shots every 2 months. So in this case, we told them, okay, let's try to extend it a little bit since your vision's good. We'll try to extend it to 2.5 months. And then we have the patient comes back at 2.5 months. And you can see here that the yellow line is starting to go up, indicating that at 2.5 months, the efficacy of that drug has started to wane. The edema is starting to come back. And even if the patient's vision hasn't deteriorated, sooner or later at this trajectory, it will. So this patient doesn't want shots that frequently. So in this case, since we know that we can only at present achieve a good control of his edema at every 2 months, then we offer some suggestions. So Adrian, do you have any comments so far?
I think certainly one of the advantages of Ozurdex is the ability to extend treatments out, typically to at least 12 weeks and sometimes longer than that. But I think there are also other considerations. Ozurdex should not be used in patients with advanced glaucoma. Certainly patients who are already on 2 or 3 drops, you have to be very careful with significant visual field defects. It's been shown that they are more likely to develop steroid-induced ocular hypertension and progressive loss. So there are limitations to Ozurdex. Some patients develop, for example, problems with retinal detachment or migration of the implant. So it's not a cure-all. But what are the indications, Harvey, for you, other than duration, of perhaps patients who may not respond to anti-VEGF and will need Ozurdex?
Yeah, so in this case, it's a 69-year-old female. She's already had her cataract removed, and at the time when she's had her cataract removed, of course, she received steroid drops, and we have no record in her history of an increase in eye pressure. So given all of these, we see really no contraindications to placing this patient on Ozurdex steroids. But we can also present an alternative of going back to the every 2-month injection cycle and see if you can extend later on. Any other alternatives for you?
Of course, the newer generation anti-VEGF agents have had some benefit in terms of extending durability. So I would perhaps consider moving to faricimab or Vabysmo or even Eylea 8 milligrams. The key here is to use a treat and extend. If you want to extend out to 16 or even potentially 20 weeks, you have to do so when the macula is dry and not when the fluid has already recurred. And so the patient needs to understand that we're going to treat at visits at which the macula is dry and then extending the duration by up to about 4 weeks. And we've been able to then successfully move the needle from Q8 to Q12 or Q16. And if you can achieve that, perhaps you don't often need to use Ozurdex in these patients.
That's right. So for this case, the patient opted to try the Ozurdex, and she did well. So that was a relatively simple case. And let's go to a more complex case. You can see here on the far right, there's an injection symbol out there, and this actually tells you this patient has received 33 injections all in all. Okay, and this patient was actually a physician. Her one eye underwent photodynamic therapy and wound up with 2400 vision from retinal atrophy. The other eye was being managed elsewhere, but eventually she was referred to us because the first doctor was having difficulty controlling her disease activity. So when she came to us, we said let's start off with every 4 weeks of Avastin. And this seemed to work for a while, but after some time you can see some signs that the patient might be developing tolerance to the Avastin. And then we decided maybe let's try getting the injections every 2 weeks, which is, I think, quite intensive already. But even with every 2 weeks Avastin, you can see here, down here, that we're not really getting good control. You see that yellow line indicating central retinal edema fluctuating quite extensively. And then we even tried Eylea, that's the yellow line, but you can see that's actually made things worse. So now we're in a not so good situation, and at about this time, brolucizumab was introduced in the United States, and we were able to convince Novartis that this is a only eye case. Maybe we can use the brolucizumab on a compassionate use protocol. And this is in the middle of the pandemic. We were able to still get permission to import the brolucizumab, and we started this patient on brolucizumab with good response. And then later on, as Adrian pointed out, we tried to do a treat and extend as the retina dried out, and eventually we were able to get her off it. Any thoughts on this, Adrian?
Well, I think in this day and age, knowing what we know about brolucizumab, I think using it in only eye may be a little bit dangerous, and I think I'll lose sleep over that. Certainly, it is a good drug in terms of drying effect, but the unpredictability and the idiosyncratic response, especially with respect to intraocular inflammation and occlusive vasculitis, makes it a very difficult first choice. It's very often now a third or fourth choice. In fact, in Singapore, the health authority did not approve brolucizumab for that very reason. So I know in many countries that is still the last resort treatment. The second approach, I think, here would be to do an FA-ICG again. In some of these cases, they may have polypoidal choroidal vasculopathy, and then locating these polyps, closing only the polyps down with half-fluence photodynamic therapy, I think would work in trying to achieve quiescence without the risk of RPE atrophy. So I would revisit if this patient had been treated so frequently and also at some point done an FA-ICG to look for polypoidal.
Yeah, so actually we did do an FA-ICG at some point, and as you can see here, there's actually a scalpel sign, and that's actually when we did the photodynamic therapy. And I think that enabled us to further extend out the brolucizumab, and eventually enabled us to helped us to stop the treatment. And I completely agree with you. Brolucizumab is not often used in our practice, but in this case, we were between a rock and a hard place, and I think we were lucky that she didn't develop any complications from it. Okay, so now let's go into this case. I think they're telling us we're running out of time, so this might be the last case. So this was a 52-year-old female with blurred central vision in the right eye. We did a fluorescein angiogram, and there's some fuzzy hyperfluorescence in the central macula. And on the OCT, we could see subretinal fluid and maybe some drusen. And in this case, we're wondering whether it's a CSR or choroidal neovascular membrane or a polyp. And we actually did OCT angiography, and we actually saw these dots lighting up, indicating that there may be a polyp there that's leaking. On the OCT, we explained to patient that they had subretinal fluid, and this red area is the area with swelling. And because of our OCT angiography findings, we concluded she probably has an abnormal blood vessel there that's leaking, which we would not see if she had central serous retinopathy. And this prompted us to initiate anti-VEGF treatment, and she actually responded, and we're still treating her for now as a treat as needed protocol. Adrian?
I think this is a very nice case because this is often a conundrum. About 16% of patients first diagnosed with acute CSC actually have an underlying choroidal neovascularization. And they will not settle, number one, with just observation. And number two, if you leave them, they can advance quite quickly, ending up with hemorrhage. So here you can see the response is quite typical of CNV, with anti-VEGF achieving dryness. If this was typical CSC, giving anti-VEGF is likely to have no effect at all, right? So I think this is really one of the main uses of OCT angiography now in my practice, to differentiate CNV, underlying CNV, from true acute CSC, where you can observe for a little while.
Okay, 2 minutes. I think they're letting us do one more case.
No, it's okay. Ignore the timer.
Ignore the timer. Okay, we're going to ignore you, sorry. But just keep flashing those cards. Okay, so this one is a 82-year-old diabetic who underwent pan-retinal photocoagulation, and he consulted for a recent drop in vision. You can see that there's a drusenoid-like deposits here in the central fovea, these yellow spots, and on the B scan you can also see an elevation of the RPE here, which we think is also drusen. And here we're trying to figure out what's going on. Is this dry AMD that's progressing, or is it something else? And you can see on the OCT angiography that there's actually areas of hypoperfusion here on the superficial scan, and on the deep retina scan you can also see more extensive areas of hypoperfusion and maybe a blockage of or decreased flow through some of the blood vessels. And you can confirm this on the combined image. And in this case, we're not sure what this patient has, so we we looked at the angiography analysis of the Retina Workplace, and we actually saw that compared to a previous scan, there was actually a decrease in the perfusion of this patient, and we were explaining to the patient that maybe he had some further occlusion of the perifoveal blood vessels that caused him to lose some vision. So at this point, we asked him if he was actually taking any blood thinners, and he was not. And so I talked to the cardiologist, who probably started to scream at me because his patient, he was afraid, would bleed in the brain, and this might kill the patient. But eventually we were able to placate the cardiologist, and he agreed to start with a very low dose, I think, of aspirin. And the patient actually came back with improved vision, and there was maybe a slight increase in the patient's vessel perfusion. So we don't know if that's really what enabled the patient's vision to return, but I think if this was dry AMD, adding aspirin would actually not do anything. Any thoughts, Adrian?
I was just concerned that there would be small fronts of choroidal neovascularization, either iatrogenic or just a secondary CNV. And I would have watched the OCTA bring the slab to the choriocapillaris, OCP, outer retina, very closely, and then watch him over about 2 to 4 weeks. Because if there is indeed choroidal neovascularization, we expect to see worsening of increased flow through that lesion, the flow signal, and sometimes even shroom, which is subretinal hyperreflective material. So in this case, probably your diagnosis is correct, the fact that the visual acuity improved. But before I start anticoagulation, I want to make sure that the patient does not have choroidal neovascularization.
Yes, that's a good point. And we actually looked very closely at the flow in that area, and we didn't seem to see any a flow above that lesion. And that gave us a little more confidence to convince his cardiologist to start anticoagulant treatment. Plus, this was the good eye of the patient. The other eye was worse. So the patient was anxious to do something to get some useful vision back. And he was a prominent lawyer in the Philippines. Okay, so a few words about the EQ workplace. I think you've heard some discussion already about the EQ workplace today, but I think we'll focus some time on how you can use the EQ workplace combined with the Retina workplace to aid in the management of your patients. So you know the EQ workplace, it helps you plan cataract surgery, align your toric IOLs to get the best refractive outcomes. But you can also access this EQ workplace on the same computer that you can look at the Retina workplace. And for patients who are undergoing cataract surgery, what we like about the IOL Master, it does actually give you this mini source OCT image of the fovea. And we always make sure we look at this, especially in patients who are going to receive a premium IOL. And we want to make sure that this is normal looking before you proceed. Or you can actually, in some cases, automatically include the OCT as part of your pre-operative workup. Maybe we can ask our experts here what you do.
I also do the screening a lot, especially if you're going to implant the multifocus lens. I do totally agree that previous investigation should be at least through your eyes and make sure that everything's okay, instead of you accidentally or surprisingly know it post-operatively. It's going to be a lot of trouble. Yeah.
Yes, Adrian?
The same standard, I think, would be an OCT both of the macula and the optic nerve head as a form of screening. And of course, with the forum, we have the ability to put up everything else. So biometry is there, the endothelial cell count is also there. So, you know, at one glance, I will have all that information. I'll be able to go through this before surgery.
Yes, the presence of the cataract might preclude you having a good image of both the nerve and the macula. So you can use the OCT to help you understand what's going on. So this is a patient. She's a 77-year-old female. She denied that she had diabetes, just maybe occasionally elevated blood sugar. She comes in with a vision of 20/70 with a hazy view of the fundus. Oh, it's not moving. It's moving here, but not there. Try. Okay. Okay. Oh, and now we have the latest news in Seoul. Okay, so 20/70 vision, hazy view of the fundus, so we couldn't really see the retinal details very well. This you can see here a rather dense dark brown cataract, and we plan to do cataract surgery. But when we looked at the IOL Master foveal scan, you could actually see fluid spaces here, and this is already a red flag for us. And we advised this patient that she had there it is. So you can see here that there are cystic spaces on the IOL Master scan, confirmed by a OCT scan. And this patient was advised that she had diabetic macular edema. We could remove her cataract. The vision might not be great, and she will definitely require treatment for this. The other way is we could inject her with anti-VEGF medications, but that might also not improve the vision because of the severity of this cataract. And as we say, if you tell a patient before a surgery, it's an expectation. If you tell a patient after the surgery, it's a complication. So here, the patient decided she's going to remove the cataract first and deal with whatever consequences later. For these patients with macular problem, we avoid multifocal lenses, so we put in a monofocal toric lens, and the EQ workplace is very helpful in allowing us to plan the surgery and put the IOL in the correct axis. So after the surgery on day one, the vision actually was 20/20. The patient was happy, but by the third week, it dropped to the pre-operative level, and now she's unhappy. But when we showed her her OCT scans and worsening of the edema, she now understands that we were telling her the truth and she should get an injection. And this was her injection pattern. So, and later on, we wound up just injecting her as needed. So, Adrian, any thoughts about this?
Sometimes we see another situation where a diabetic patient does not have diabetic macular edema, so you list the patient for uncomplicated cataract surgery. A few weeks later, or sometimes even 1-2 months later, they develop cystoid macular edema, and then you're unable to really be clear, is this pseudophakic macular edema, Irvine gas, or is this just diabetic macular edema? And in those instances, the treatment will probably be the same, but if it's DME, I will go more towards anti-VEGF, and if it is a Irvine gas, I'll treat with topical NSAIDs and Prevfor. So sometimes an angiogram is useful to detect disc hyperfluorescence, and that's usually a very good differentiator between the two.
Okay, so I think we're definitely ending this. All right. Thank you very much for your kind attention, and I hope you've seen the real-life workings of this system.
So, hi, good afternoon, everyone. I think we're going to start our session. A Glaucoma Workplace by me, Manchima Makornwattana, and Dr. Geoffrey Chan. We're going to tour you through the glaucoma workflow. I would say treating glaucoma is a marathon work because, as you all know, we saw patient at first. If patient has suspected glaucoma, you won't treat them, but you have to stay with them along the way through, maybe 10 or more years. And during those years, you have to, it's not working. And during this whole years, don't worry, let it be. Oh, it's not moving. And during those, the challenging is you have to know that this patient are developing glaucoma or progressing of glaucoma. So you can treat them at the appropriate point and make sure that this eye will be preserved vision for the whole life, right? So your work is actually a lot, not just only see patients at that one time and you can tell, but you need the long-term records to see how your partner in life, the same thing, is really still, with you, or he deviated his mind to someone else. So you need long-term follow-up to see that. Same thing as glaucoma treatment, right? And the reliability of document is really important to see that. Don't worry, let it go. Yeah. All right. So in each steps of follow-up, you have to do all the same thing. Review the patient files because it's 10 years, so you have more time to spend with those. The history taking of how many, 6 months that you haven't seen each other, is there any new things happening? Or this investigation, is there anything happen or any change compared to the past? Discuss with them and check out. But with the discussion, it's not easy because patients also, they know that they have glaucoma. They want to get blind, definitely. But they're not so sure that this treatment is needed or anything else. So although it's documented, it's really hard for us to spend the time within just a couple of minutes and then decide it to that patient. I'll let you through this as well. Let us imagine if you leave the house with very, very bad traffic that morning, and you found out that you forgot your purse, the whole thing, but you still have your phone. I believe that you still move on to your work, right? But if you have everything except your phone, you're definitely going to make a U-turn and get it back. Why? Because your phone is actually everything in there. Like I just went to California for my son's graduation. You know what? I have lots of things in my purse. I have cash, I have coins, I have credit cards, I have everything, passport and everything. But my kids, they hold just only one phone, everywhere. That because if you have one machine that's very effective, it will save a lot of your time and also make a lot of improvement in quality of life. I believe that some of us will be very familiar with this, the paper that you have to flip around, back and forth. It's not working again. Okay, I have to put, okay, here. You have to flip back and forth. Remember the visual field, right eye, left eye, 24-2, 10-2, and sometimes the date and month is slightly different in each, so you have to make it like, orderly and sequentially, and make it through your eyes to remember how it was, so you can compare them and see is this progression of glaucoma or not. Not excluded about the reliability on that test and things. Lots of work that you have to do, right? I believe you can imagine this. Okay, I know how to deal with it. Here. But when we move to the EMR, definitely no paper, a lot better. But the EMR itself is not exclusively handle the ophthalmology for you. So they have lots of EKG, PACS, MRI, and when you list them when you list them here, there are lots of things that you have to take care of, and you have to sequentially see the fundus photograph on that day, on this day, the zoom in, the zoom out, the right eye, left eye. There are lots of things also. But if we change it to the, if we change it to the forum, it's going to be a lot less of work because it shows you in just only one place. And you can click around, play around, compare head to head from this to that, and that's going to make you lots of easier life. And you have more time to discuss with your patients. The thing that I love, it's really tricky me though. The thing that I love is you can show that to the patients as well, that the left eye is about to have a problem, and the line will make them more understandable. And patients can ally with your treatment a lot better more. I'll show you in my case. All right, and they also can compare if that's a mimic of non-glaucoma. So you can compare with the OCT, fundus photographed, the visual field, the RNFL defect. Is it related? Is it really glaucoma? So it's a lot easier for you. You can deselect them. You can zoom them in one piece to see how is that in that day. So there are a lot of saving. There's something coming up here. Okay. All right. So we threw my case. This is the Thai male, 42 years old. He saw me in 2020, which he has been diagnosed with POH since 2013. That means at the age of 35, he has been diagnosed with glaucoma. From other hospital though. No underlying disease, very strong family history of glaucoma. And he's been currently taking the fixed combination and then switch to something else because of, let me show you through. His vision is pretty good. In the left eye is slightly worse. The tension is 15 in both. The cup-disc ratio is like this. So it is definitely glaucoma. And this patient has been told many years ago that he is having glaucoma, especially in the young. He has been treated, but very poor compliance. He's been back and forth with the doctor. Sometimes he got the medication, he used it for a couple of weeks, a couple of months, and then he stopped. And when he feels that he has like irritation, he's just concerned of his glaucoma and then get back to the doctor again. And that doctor also always told him that you are having glaucoma and it's getting worse. So the first day that I saw him in 2020, I also expressed that you probably go blind with this disease if you leave it like this. And I do recommend having the laser treatment because it will increasing the compliance to the patient, right? Because if you have no eye drops, it still contain the function of your visual field that is not progress. And also because he has a lot of irritation after using the eye drops, that's why he complies less. So I follow up him, advise him and follow up him. No. Okay, actually, I'm sorry with that. Okay, after discussing, he lost again. So when he get back, oh my gosh, sorry. when he get back, I just show him this. Before he get back, he lost for 4 months, for around a couple of years. And those 2 years, he saw many doctors. Those doctors also expressed him to treat, but he denied. So I make decision to talk with him through, and then show him this records, and show him that the left eye is getting worse. With all of the document, as you can see here, he saw lots of doctors, but they all has been lost follow-up by him. Every 3-4 months, he will lose again and then get back, every 6 to 8 months, and no medication. So I show him this, and I talk to him through and draw the line with this one and reach it around here at age of around 60 something. He will hit the visual disability point, and that can stop him for lost follow-up. So with that, he finally make decision to have the SLT with us and still follow up with us at least every 3-4 months as we recommend. So that is actually a very, very good technique or a good trick to show the patients to comply with you. And definitely, because he's still very young and patients right now has longer lifespans, definitely if we lose it like this, it will reach the point very fast. So patient education with realistic and strong data is really important for glaucoma treatment. All right, this is my next case. That one is the one that no need follow-up, doesn't want to know that he is having glaucoma. This patient is a Thai female, 65 years old. She's a professor of radiology, consulting for glaucoma in 2020 with no problem. Vision is actually quite not bad at all. The eye pressure is around 18, but when we see his fundus photograph, you can see that definitely strong RNFL defect around here. In the right is slightly more than the left. The visual field test is like this. So we discussed with her, I think she is having glaucoma. We do the laser treatment and then go her through the cataract surgery with the GSL. In the right, I do the monofocal toric lens implant. In the left, I do the EDOF toric lens implant. Post-surgery, her vision is pretty good. And he has the eye pressure under low teen all the time. So I recommend to see her every 6 to 8 months at first, and then finally it would be 8 to 12 months with the visual field test, OCT, and fundus photograph. However, she get back to me every couple of weeks. And I said, what's going on, doctor? Do you have any things in mind? And at first, she's saying nothing. She said, I'm just feeling irritated, so I would like to see you. So we do the visual field test again, we do the OCT again, and another couple of weeks, I see her again. So what's going on? So I just talk like detailed on her what is going on. She said she doesn't want to go anywhere. She doesn't want to go like traveling around because she felt that her vision is less. And I tried to convince her that everything seems to be under control. And the visual field that it has been happening actually with you for more than a couple of years before the surgery. Even after surgery, it's getting slightly better because the cataract has been removed, but she noticed that visual field defect more because definitely she's a doctor, so she understands, this is not the cataract, so this is the glaucoma. It's still sustaining there, so she's aware of blindness and she doesn't want to go anywhere and also have suicidal idea. So I just sit her down, talk her through, show her lots of documents that we have, the visual field that she has. This is in 2020, this is in 2024, 4 years after, 5 years after. Everything seems very stable. And finally, right now, we see each other once every year. So that's a good news, right? So I would say there are many types of patients. This one is too conscious and doesn't make sure that this is stable. So you also have the tools to take care of that and make her happier and live her life better. So in these couple of things, I would say the time spent with patients are way more important than just telling them just one sentence that everything's good. That is probably not enough. So you probably have to dig into the idea of her or he or his to see, is there anything in there that you need to clear off or not. Over or under treatment is definitely unacceptable. And if someone tried to tell me that the technology will replace you, I would say definitely no. Because the technology will not replace great doctors, but in hands of great teachers or great doctors, it can be transformational. So that also will help us with the happy practice and also happier patient's life. Thank you so much.
Okay, so a good half of the room. So look, I think today we've, my colleagues and I have all kind of shown how powerful, workplace and forum is potentially for our patients. And I think a recurring theme is how powerful it is for patients' education as well, to increase compliance and to show our patients, exactly what's happening. So my brief with this session was actually to actually do a hands-on. So I think because 50% of us might be familiar and 50% of us might not be familiar with Glaucoma Workplace. My brief was to basically show my personal workflow. And I think it's really nice that we've got all our glaucoma doctors in the room as well, and our retinal colleagues. So if there's any tips or tricks that anyone would like to kind of intervene with, absolutely feel free to do so. But here's a 66-year-old guy. And what's really nice about glaucoma or forum is that if you see this kind of button here, there's a export all DICOM files. So look, I'm from Australia, right? And obviously we don't share our network. But you can really, just with the click of a button, export all the patient's past history and DICOM files, into this patient was about 400 megabytes, send it across the world, give it to the patient on a USB, and they can actually, upload it wherever they go with all their previous OCTs and images. So I think that's really nice. Look, I think from the glaucoma standpoint, here's our example patient. As Adrian showed you before, here's a patient that I've seen relatively recently, and some people say, Jeff, some of my registrars say, how do you get multiple images on at the same time and multiple dates? What you can do is just basically hold on to your shift button and left click on the separate dates, and basically now you'll have the ability to scroll down and see all the relevant images across different time points. And by holding the control button, you can really say click on the visual field or what have you, and basically if you hold the control button, you can really right click and bring specific things side by side for display. So you really can be quite selective about what you want to do. Now, basically, is this patient getting worse in terms of their glaucoma? Here's a 66-year-old guy, and we've got a nice little video to share, but he's been sent because he's had previous glaucoma surgery, so he had a Presiflow microshunt. And the concern was that initially his pressure was doing well, pressure was 12, but now this poor gentleman has a pressure running in the 20s, and essentially we're concerned that the glaucoma surgery has failed. So is this glaucoma getting worse? Under the Patients tab, the most powerful thing for me, just forget everything else. If you're going to click one thing, you just click on the structure function GPA. Okay, and so here's that live demonstration of the patient. Now, just to be aware, you can actually select how you want to view the patient's information yourself. So this is customizable to you. You can actually have different profiles if you've got different surgeons or different people across different hospitals. And so here earlier, you can see that here's a default 1 display, here's default 2 display, and that's my typical display where I've got the patient's visual field index, mean deviation plotted, and average RNFL thickness, etc. So basically, forgetting everything else, you can basically, in the click of one button, show your glaucoma patient or make quick decisions as to whether or not their glaucoma is stable or getting worse. And here we've got ODOS, so we can quickly just basically, cycle between the patient's right eye and their left eye as to whether or not, the information's there. And once again, my colleagues have shown you what's powerful about the, Forum Glaucoma Workplace in particular is that on the top two rows, we've got our trend analysis. And that's basically, the slope that you can show your patient with the linear regression of how things are going over time. What's nice about it is that each time that you, double click on each one of those dots or event dates, you can then quickly pull up the visual field data for that particular event. And, for example, in this patient, you can see that things are getting worse in terms of their visual field. You can see that they're starting to go off a cliff. So whereas the eye has been relatively stable this whole time, you can see that things are now starting to decline as the intraocular pressure is creeping up and previous glaucoma surgery has failed. So if you've got a nurse that you can trust, you can basically ask your nurses to do this. I basically do it in clinic, and Manchima touched on this, which is basically setting a dual baseline. So here's a patient that's been seen, and if you mouse over this, you can see that this is a result from 2017. And over time, we can see that each date is tabulated with a summary of their indices. If we add a dual baseline now, so if I click on this button up here, we can actually then add different kind of events over time to actually set different trajectories. So here I'm right-clicking on the dot, and here I can say add in when the patient had surgery in 2023. And by doing so, you can actually see the initial trend analysis from before their surgery, and now you can see that since their latest surgery, you can see a new trend analysis. So that's basically adding a dual baseline. The other way to do it is to actually click and drag. So this is what I like to do as well if the patient's had surgery. So let's go back to a non-dual baseline. Here's that view that we saw originally, and here's where the patient had surgery. You can actually click on the dot and literally drag your baseline onto where you'd like to set things. So here we're going to click and just drag onto this dot here. And here we can actually see that we can actually tell Zeiss to forget about everything the patient had before. This is going to be our new baseline. Patient, this is where you've had surgery, and this is where things are definitely going downhill. There we've got the mean deviation slope. We can see that this patient's on their VFIs are, relatively rapid in terms of minus 1.3 based on their new progression, which is not kind of clouded by the previous slope. Down the bottom, here's our event analysis where on the progression map, these are the triangles. And basically, black triangles are bad, is what I tell patients, right? So here's that visual field superimposed over time. And quickly, you can show your patient, hey, these are areas where consistently your vision is dropping and your visual field is deteriorating. Don't believe me? Let's scroll down and let's have a look at the progression maps based on optic nerve thickness. And here we've got orange for consecutive losses and red for definite areas of thinning over time. So here's a patient that I really don't need to convince to say, hey, you know what, red is bad, okay? And basically, you're going to need something done. Here's your ganglion cell analysis, and it's all there for you. So, glaucoma is so simple, right? Like, everyone should be running their busy glaucoma clinics now that we've got, Forum. And what's nice about this is that, if you've got a Claris, it will also integrate, the Claris fundus photo with a automatic, segmentation. Just to break it up. So at this point, I'm going, hey, your glaucoma's worse. And so here's the patient's surgery. They've got a failed Presaflow microshunt. So, there we go. So, so we've got to, So, because we all love surgical videos, right? So, here's the surgery. Here's the redo, right? And I'm going, conj wasn't mobile, and it's really not mobile, right? Because I'm trying to use the lignocaine to viscodissect, and that's just nothing but tense fibrotic tissue. This is the Cambridge technique, where, I like to apply mito, specifically in my redos with a Wexel sponge posteriorly. And here's that ball tube implant going in. And we can see all that kind of subconjunctival fibrotic tissue that we're dissecting around the stent. We just want to secure our ball tube with a through the eyelids. And here's the IOCT showing my previous PreserFlow, and I'm happy with how that PreserFlow is running there. So, where PreserFlow surgery has failed, I really quite like to take the PreserFlow out and use the same track, because with my mani blade, it's often quite a nice tunnel. So I'll typically dissect the PreserFlow shunt, pull it out, and because I don't want to hurt the eye anymore, I'm going to reuse that same track in terms of my pawl. So I find that quite a nice technique. And here's the pawl tube going in the eye. And because I like to play around with the IOCT, because I got a lot of time on my hands, I like to basically film over that, and I like to always see how it's running and how the tube's moving through the sclera, and that's kind of scleral entry, and I'm happy with that in relation to the iris. So basically at this point I'm saying, yep, good job everyone, time to go home, right? So we're going to cover things up with our scleral patch, secure the scleral patch, and here you can see it's really quite tight, but it comes together well. But that's really quite fibrotic conj tissue, right? So for the training glaucoma surgeons, I always say we're conjunctival surgeons, right? At the end of the day, we're not really glaucoma surgeons, but and that's me, liking to check my pawl tube and its insertion away from the endothelium. So that's that patient. That was just out of interest to break things up, because I didn't know how entertaining GPA analysis would be. But basically, we've got our document display. I think some other things that are useful to know, and I think Manchima had this in her talk as well, but one of the other powerful things that I like to do is actually create a report. And so if you've got well-trained nurses, they should be able to do this for you or to do it on Cirrus. But just to work through that, we can actually left-click on Create Reports. And the one thing that comes up is typically structure function. And so I instruct all my staff to basically create this report for me for every new glaucoma patient. And that's basically the summary of all the things in one. So here we're just going to work through that. It's all spelled out for you. I mean, if you can read, you can use Zeiss Forum. So, step number one, select the Humphrey Visual Field Exam. So let's do this patient's right eye. We're going to select on his last field, and let's click on Next. Now it's going to ask us to select the OCT exam that you'd like to kind of display. And so once again, we're going to choose one from the same date and click Next. Now we've got further optional OCTs. You may or may not want to include that. Here we've got the GCL IPL analysis, so that's always nice to include. Let's choose that. And lastly, we can actually choose a fundus image. So here I'm going to choose the patient's, Claris image. And this, I actually chose this case on purpose for you guys, because here's the patient's Claris image. We can do it in kind of, black and white, or we can do it in, color. So let's choose the color. And so once we've got that, we can basically go to the bottom right and create report. So we're going to create a report here. And so basically this is what you got to get your nurses to do, or whoever you want, or you can do it yourself if you have enough time in your busy glaucoma clinic. But here we're going to create our report. And here I'm just going to show you, we've only done it for the right eye, whereas we can do it for the left eye as well. But here's our structure function report that comes up. And so here we can see, once again, we did the report for the right eye, we've got the visual field, structure function analysis. And here I chose this on purpose because here, if we actually go back to our original Claris image, the weakness here is that this is artifact, right? And so just as a word of warning, if because my patients typically aren't dilated when they have the Claris, but if you want a good image, do think about taking the photos with the patients dilated at baseline, if that's okay. So we're going to quickly run back and select our fundus image, and we're going to select that side now. And so we're going to create a report with both eyes. And as you can see, that's how quick it is to create these structure function reports. And so now we're going to rerun it with our right eye and our left eye. But just to show you the advantages, and in truth, we've got to show the limitations of the system as well. So here's that image with a lot of artifact overlying the optic nerve, where segmentation couldn't be accurately done for the optic nerve. But more typically, you'll get a very nice image of the eye if there's no artifact available. And from this one structure function report, I mean, like, you know, it's all here. Like Manchima said, you know, you've got your visual field losses, you know, overlaid with your structural OCT analysis just to see if there's a disc field mismatch, and all the important parameters of the optic nerve as well as RNFL and ganglion cell maps. If you're ever really interested, you can actually go, because there's actually a page number 2 that most of us never look at. But, you know, basically that will show you all the different zones of the optic nerve in terms of breakdown if you ever want to see top and bottom. The only last thing I'd say about, so if we're going to go back to the, you know, patient directory, once again, if we go back to structure function GPA, we've showed you that we can change our baseline. We've showed you that you can set a dual baseline. But you know, really the power is in just, you know, showing the patient exactly what's going on and educating them in front of you. So I think, you know, I think most things have been covered. So that's just a really quick rundown of how I use Zeiss Forum. Yeah. Thanks. Yeah. Does anyone have any other tips or tricks they'd like to share in terms of how my other colleagues, other things that you guys may or may not do? Pretty much it, yeah, pretty standard, yeah. Oh yeah, Werner, yeah. Absolutely, absolutely. Yes, so here I've actually demonstrated it, and thanks for, because I know our retina colleagues kindly demonstrated that. But here, you know, this patient's had surgery at this point, right? So, you know, if you right click on any kind of visit, you can, I'm not going to add an injection, right, because it's my glaucoma clinic, but here we can actually right click, we can add our surgery, and here you can see that, you know, there's different templates available if you've pre-made them. But here we can just say, you know, the patient's had right pole tube surgery, or pole tube surgery, because we know it's the right eye. Yeah, we can assign a color, you know, select on laterality and add that. And basically going forwards, now if you mouse over it, exactly as you said, now you know, and it's quite nice to present in conferences and all that. It's quite powerful to have all this together in terms of the patient's, you know, journey with us. Thank you so much. All right, enjoy afternoon tea. Time's up. Time's up. Thanks.